I became interested in this topic because I wanted to understand what the ideal imaging surveillance frequency was for patients who have thoracic aortic aneurysms. And I wanted to see if we were really over-screening patients and if we could develop a more effective and evidence-based screening protocol, because current guidelines are only based on level C evidence. The findings that we found in this study were what we had expected and how we have currently changed our aortic surveillance protocol. So essentially, we found that, on average, patients have the highest risk of reintervention 3 to 4 years after their proximal aortic surgery, and the majority of these reinterventions occur in the descending or thoraco-abdominal aorta, and that's helpful for helping us modify our screening interval. So now we screen patients less frequently and after the time when they're highest risk for reintervention. Based on the findings of this analysis, the current guidelines from the AHA and STS based on the 2010 thoracic aortic management guidelines probably need to be modified. Currently for dissection, guidelines, for example, recommend screening at 1, 3, 6 months and then annually with no stop date on screening. And in this analysis, we show that that's probably over-screening, which can lead to increased costs and increased radiation exposure. So we feel that with a more conservative screening approach that's tailored to patient-specific risk factors, either based on whether they had a dissection or a proximal aortic aneurysm, we can try and have more effective screening for the times when patients are at highest risk. And I think that probably when the new guidelines are developed for screening for aneurysms, that's something that should be incorporated into the guidelines. One of the limitations of this analysis was really twofold. The first was our duration of follow-up, which was relatively short. It was about a 4 to 5 year follow-up period. So some of the patients in this analysis will go on to continue to develop reinterventions, but we anticipate that during the study period they had their highest risk of reintervention, and that risk would sort of either be stable or decline. The other issue is our percent follow-up rate, which we expect is about less than 3%, after 2 years. So I think our follow-up is pretty good, but it's always possible that patients may go on to move or go to other areas where they may get lost to follow-up. So I think just continuing to keep track of our reinterventions, reevaluate patients that come back for surgery, and that had index proximal surgery at our institution, and then kind of continue, hopefully at some point, doing a second analysis to see what our reintervention rates are after beyond 5 years, I think would be very helpful.